Hello and welcome to Live 2021 Nephrology Campus and the series of webinars we are doing currently over the recent months. So we are talking about current trends in nephrology, and today we do the webinar number 6. You as an attendee, you are muted all the time, but you can ask your questions in the chat function on the right corner, and you see the button. So again, my name is Christoph Wanner. I'm a professor of medicine at the University of Wuerzburg, and I'm chairing this series of webinars with Professor Peter Stenwinkel, the professor of medicine at the Karolinska Institute in Stockholm. Today with us we have Professor Dick de Zeeuw. He is a professor in clinical pharmacology at the University Medical Center in Groningen, the Netherlands. Professor de Zeeuw has spent his entire professional life in designing and executing large clinical outcome trials. You remember 20 years ago the RENAAL trial, where he was also prominently part of this trial. And over the next years, I can say this today, Dick de Zeeuw made a difference in the understanding and the treatment of patients with chronic kidney disease, diabetic and non-diabetic patients, and progression of chronic kidney disease. He developed a model of precision and personalized medicine over the recent years, and today he will talk about precision medicine, a clinical decision support system to tailor therapy and improve renal and cardiovascular outcomes using a multiple parameter response score. So please, Dick, the floor is yours.
Thank you, Professor Wanner, Christoph, for these kind words. I'm getting a little humble when you speak about me this way. And I, on purpose, gave you the difficult task of reading a title which is much too long. And I hope to help you as an audience, dear colleagues that are listening to this webinar, by explaining to you why this is such a long title and what it actually entails. And I think that the message that you should take home is that I think that the precision medicine is time for it now in our daily clinical care in treating patients with chronic kidney disease. And it stems from the fact that I believe that precision medicine is, or personalized medicine, whatever you like to call, has a long tradition and definition already, but has never really entered the era and the area of chronic kidney disease or chronic diseases in general. And for that, we need to go back a little bit in history. Well, first of all, what is precision medicine? And the definition, if you look it up, is that it is a form of medicine that uses information about a person's genes, proteins, and environment, and this to prevent, diagnose, and treat disease. However, if you make it a little bit more palatable, you should have examples of it. Is there something already in the presence where we can state that is truly precision medicine? In my mind, we should go back to bacterial infections caused by a bacteria, obviously, treated in the past with penicillin, which was found by chance, right? And then it showed when we were treating infections that to penicillin, there were a lot of non-responders. So something like we have currently in our chronic kidney disease treatments. But that has changed over the years when they experienced that they could actually sample the bacteria from the blood, culture it, and then test actually in the Petri dish, as we all know it, from our training in medicine, that you can actually do it yourself and then test for what drugs have an effect on that bacterial culture and growth, and then apply it in your patient. This is, for me, the true example of precision medicine. You treat what is there and not something else. In cancer, there's a second example where we are trying to do it. Started obviously with a cancer cell and nitrogen mustard. a lot of non-responders. And now we sample the tumor, we look into that sample and that biopsy and try to detect what is causing the growth of these cells, what's the mechanism, and then we try to find a drug that attacks that particular mechanism. And we are, at least to some degree, successful in cancer. So in case of a bacterial infection and cancer, we have found that we need a specific drug for a specific patient with a specific disease. That is actually my definition of personalized or precision medicine. And it means that you move from one size fits all to a fit for each size or a fit for each patient or for each disease. Now, how is that next to the infection and cancer with diabetes? And we know that diabetes is a disease with a worldwide growing prevalence and with an incredible high morbidity and mortality. In fact, I think it is one of the worst diseases and even outweighing cancer nowadays. Now, what is the treatment status in this particular case, where in both diabetes and non-diabetes, the kidney is heavily involved? My talk will focus on this chronic kidney disease, this CKD, touching on both diabetes and on non-diabetes, and what are we doing about it? Now, if we look the status today, then we treat renal and cardiovascular disease with one size fits all, because the guideline that we have for the treatment of diabetes just gives us a recipe that should be applied to each patient. Now, I know that you can say, well, that has changed over the years as well. We make differences between patients that have just clean disease or comorbid conditions and what have you. But in general, CKD treatment has a general approach to it. And the question is that correct? And I think the answer lies in the following slide. This is what we would call a change in the era of treating chronic kidney disease. And Christoph already told you I was present at that time when we started with the RENAAL and IDNT trials, two trials that were attempting to stop the progression of kidney disease by introducing a drug that intervened in the renin-angiotensin system, in this case, angiotensin receptor blockers, losartan in RENAAL and irbesartan in IDNT. Well, first I should say here that, as you see here, the different stages of disease, and in particular in diabetes, but also in non-diabetes, is that it starts usually with a high blood pressure and no albuminuria. Then you get high blood pressure plus albuminuria, and then the late stages are high blood pressure, proteinuria, and a low eGFR. And during those different stages, you see that the risk, which is expressed here in end-stage renal disease and death, the risk for end-stage renal disease and death increases dramatically, to such a degree that it here actually outweighs cancer, treated cancers. The second thing you see on the slide is then the yellow bars. Then when we use these new drugs that intervene in the renin-angiotensin system and have become guideline therapy, reduce that risk. And this was a huge success, particularly also for the patients, but also for pharmaceutical industries that will make these products. At the same time, you see something that really was something getting its effect much later, is that there is a high residual risk. And to do something about this high residual risk, we entertained a lot of new approaches. We went into trying to control this progression of disease by more control of the risk factors such as blood pressure, albuminuria, hemoglobin, inflammation, and we use different drugs for that, like sulodexide, darbepoetin, the renin inhibitor, dual RAS blockade, bardoxolone, avosantan. All of you that are listening to this webinar must remember one of those trials and the presentation of one of those trials, that they all were sort of failed trials. We were not able, although we were doing something to the surrogates here with these drugs, we were not able to reduce the risk of end-stage renal disease on top of the success that we had with RENAAL, IDNT, IRMA2, and with STENO2. How come? Why didn't we get any more effect out of these added drugs that definitely had effect on the surrogates? We believe, if we look back, that this was due to two phenomena. One, there were no non-responders to the drug. So let's say that the drug was losartan. It was intended to have effect on the blood pressure, but in many patients, it had no effect on the blood pressure. That could be a reason why there was also no renal protection in part of, for instance, the RENAAL study. But also it could be that the new drugs didn't have a response or a mild response to the actual target and thus were failed. Or it could be that those drugs have more than one effect, so-called off-target effects, and these could be good and bad off-target effects. And I'll give you the example in this next slide, where in the RENAAL study with losartan, and I'm now only looking at the losartan arm, you see many changes beyond the one of the blood pressure, which is this left panel here. So the blood pressure fell in these patients. That's very clear. But what you also see here, and by the way, and that was associated, that fall of this surrogate, by a better renal outcome, as we know that will happen with lowering of blood pressure. However, what you also see here is that a lot of variation in the individuals. These are 750 patients that are depicted on this slide. Some of them have an increase in their blood pressure on losartan, some have a decrease. And although the average was a fall in blood pressure, you can imagine that those who were not responding with the blood pressure were actually not so much protected, although the whole trial was positive. But on top of that, it has an effect on blood pressure. It also has an effect on albuminuria. You see that there was an average lowering of albuminuria. There was also a fall in, or a rise in potassium. There is a fall in hemoglobin, and there is a fall in cholesterol, etc. So this single drug, which is an antihypertensive, have many effect on many parameters. And now the interesting phenomena is that some of those effects are associated with a renal protection, like the fall in albuminuria. But for instance, the rise in potassium is actually associated with a worse renal outcome. So one can imagine that when you do trials that add on to the renin-angiotensin system with new type of drugs, and they have multiple effects, of which many of them are in the bad direction, that this will result in a failed trial. So to get an approach where we try to do something where we don't have that effect of off-target, but only on-target effects, and also when you have the on-target, that you also only select the ones that actually have a response to it. There, we did several trials that actually were a good example of how we could overcome this negative approach to failed trials to residual risk. The SONAR trial is one approach in which we included only responders for the target, and we excluded patients with bad off-target effects. The other example that I will show you is the results of the CREDENCE and the DAPA-CKD studies, in which there were multiple good target effects and no off-target effects. This approach to triology, to the trials environment, is actually, I think, the way that we should move forward. So let's look at how we did that in the SONAR. In the SONAR study, we had an enrichment period in which everybody was exposed to the drug of interest, in this case, atrasentan, the endothelin antagonist. And you then can select those patients in that period of 6 weeks that have a good response in the target, which in this case was a lowering of albuminuria. So those with a good response were actually went into the trial, the double-blind trial, and those that had a bad response, which in the case of the endothelin antagonist is mainly sodium retention, so weight gain, a rise in BNP and heart failure, who were not included in the trial. And that actually resulted in a trial where it was the first time that we hit a mark of 35% risk reduction in a study that was studying progression of kidney failure. So enriching for good response and leaving out bad response at least gives you, again, a positive trial on top of renin-angiotensin system, although it still has a lot of non-responders. If you take the other approach, namely take a drug which lowers 4 risk parameters, HbA1c, blood pressure, body weight, and albuminuria, this is what SGLT2 inhibitors do. They have 4 risk parameters that they lower for the patient, then, and virtually no negative effect. Then you see in an all-comer design, so again, exposing everybody to the drug, even non-responders, responders, everything, then you see again that this drug has a huge impact also on outcome, 30% risk reduction. So 2 approaches. One is you select patients with a response and deselect those that have no good response or bad responses. Or you select everybody and expose everybody to the drug in a trial, but the drug has so many good effects and so few bad effects that it will overcome any bad effect that is there. Not only was this true for the SGLT2 in diabetic disease, which the Credence study was, but also it was true for non-diabetic disease, as you see here in the DAPA-CKD, which now shows that a very interesting phenomenon, that a glucose-lowering drug is protecting the kidney in a population that has not even a glucose rise, that has no diabetes. So it tells you the story that looking at only the target is not the way that we should go forward. In this case, SGLT2 should be judged on their response to protect the kidney rather than on their glucose lowering. But although Credence and DAPA-CKD deliver a new improved kidney and cardiovascular protection, there is still very high residual risk. So also in the SGLT2 inhibitors, there is a lot of non-response to the surrogates. And although the SONAR study, which was based on selecting responders, showed very good results, there is still need for those that were not selected because of a non-response or an off-target bad effect, because we are not dealing with these patients either, and they need to be dealt with as well. So from now on, I will switch to what I would call the future of precision medicine in CKD. I think we need to approach it from 2 sides. Trial level, we need to design new trials that allow us to select the right drug for the right patient. And on an individual level, we should create decision support systems that will allow the doctor to see whether their individual patient is actually responding to the drug with a protection for the kidney. First, to start with the trial methodology. How do we come to getting the right drug to the right patients? And we could do that by using enrichment designs. I will show you in a minute how that would look to do that in umbrella and platform design studies. For those interested, look in the literature. Very intriguing how that is, for instance, used already in Alzheimer's disease. And in cancer, by the way. And the second thing is we need to not only look at in trial methodology to a response of the target thing like blood pressure, but also to all the other effects that the drug has, and come to a multiple parameter response score. This I will explain in a minute. First, the umbrella and platform design. That could look like this. So we have, let's say, drug A from company wants to be tested for CKD protection. There is drug B already somewhere in the pipeline of the same company, or there is drug B from another company also ready to be launched, or drug C and D, etc. Preferably all drugs with all different approaches to different mechanisms of stopping CKD. Now let's start a trial where we expose all the patients to drug A and look for a response in the way that I'm going to propose in a minute, let's say the multiple response score. If there is this surrogate response initially, then the patient goes in the trial and is evaluated for protection of that drug for chronic kidney disease. If no response, then the patient goes out of the trials, doesn't continue in the trial, and can be used in the next trial that is started with drug B. If they respond to that one, they continue in that one. If not, etc., etc., etc. And so what we are doing is something that you may even already do in clinical practice. If you want to treat a patient to lower his blood pressure, if one drug doesn't work, you either combine or start with another drug until you have a response, because then you know that you may be protecting for the outcome. The other thing that we need to do is to determine how do we get a good response. We can not only look at blood pressure, we can not only look at albuminuria, we can not only look at potassium, we need to look at them all. And in particular, because we already know now that if a patient responds to a drug, let's say with a fall in blood pressure, in this case losartan, they may have a rise, that same patient, in albuminuria and a fall in potassium. So there is not only inter-patient variability in response, but there is also intra-patient variability in response, because one patient may not respond with all the parameters in a totally different way. So to know how a patient is protected, we need to know what in that patient is happening to all of the parameters and integrate them into a response score. It is a little bit similar like what we do with the Framingham risk score, right? We don't say somebody has a high blood pressure, thus he has a high risk, because if he has a very low cholesterol and he has no comorbidities, etc., the high blood pressure may be not that big contributing to the overall risk of that patient. Again, it is an open door to say also with the response, we need to know what the total response of an individual is in all the parameters to know what the outcome ultimately will be for that patient. And to make such a response score, we used a huge database that we had that showed relations between different parameters like blood pressure and albuminuria and potassium and later outcome in that cohort. So we have a huge triology base of thousands of patients where we know the relation between the level of blood pressure and the level of outcome in cardiovascular and renal risk. And also thus what a change in the blood pressure would do to outcome. Now, if we now mimic the RENAAL trial, what we are doing in this particular slide here, then we know that there was a slight fall in blood pressure. If only the blood pressure had fallen in the RENAAL trial, then the trial outcome, which is depicted here with a hazard ratio, would be a risk reduction in the trial of about 5%. If only the albuminuria had fallen and nothing else had changed due to losartan, there would have been close to 40% risk reduction. If only the potassium would have responded for losartan and it would be a rise in potassium, then there would be an increase in risk of outcome. And you can imagine that if you now look at the true outcome that we observed after many years of in the RENAAL trial was 20% risk reduction, that none of these parameters that you're looking at here actually predicted the true outcome. And mind you, all these effects that we are talking about here were the short-term effects of the drug, right? So in the initial treatment of the drug. So if you now integrate all of these responses to a multiple response score, then you come very close to what actually happened. So this is the multiple response score. It gives you an indication of if you give a drug to a patient for a couple of weeks, you look at all the different shifts in the risk factors that we are listing here, and you integrate that with this background database, you can predict the outcome of the trial. And we did that in a retrospective validation in many trials. So we looked at the true outcome in this column here that happened in the actual trial and what we predicted that would happen on the basis of this multiple response score by looking at the initial responses in the first couple of weeks or months in the risk parameters. And you see that retrospective validation, which is an easy way of doing it, obviously, is being very well. So we were very close to the actual outcome. But much more interesting is the bottom part of the slide, where we actually predicted the outcome of prospectively of trials. So we did, on the basis of the AVOID study, where the patients were exposed to the renin inhibitor used in the altitude study, we predicted that the outcome of the study would be around 20%, with a huge variability here, as you see here in the 95% confidence intervals. And actually that we would have advised the company not to start the trial, and we actually did. They did start it, and the outcome was indeed negative. Here you see the same phenomenon for sonar. We predicted a 23% risk reduction, and the actual outcome was 28. Credence, we predicted 33% risk reduction, and it was 34. So here you see that we have options with this particular multiple response score to directly in the beginning assess with a drug whether it will be the outcome of a study, if you start it, would be positive, negative, and in what direction. And we are getting, with this multiple response score, pretty close to it. How does that compare to other risk scores that you could use to do drug response prediction? There is the advanced score, and then there's the KFRI score. And you see that the actual risk, which is depicted in the blue here for the composite renal outcome, or here for the end-stage renal disease, is very well matched with the pre-score in red, whereas with the advanced score, it is not so good. And here you see it with the KFRI for the end-stage renal disease is also not so good. And so the pre-score outweighs existing scores in response prediction for outcome. And the pre-score also can predict the risk itself, so not the response, but the risk itself, as is shown here, and compares equally well to the advance and to the KFRI. So this multiple response score, this pre-score, is a very good tool to do trials in a better way for the future and get less failed trials. How does it now help you in treating your patient? Because that is obviously when you have done a trial, you came with the right drug, you still need to test whether that drug in your patient is actually doing the same as it has done in the trial. To improve the current care of a diabetic or non-diabetic patients, we should not treat each individual patient to one guideline therapy approach, which is based on trial results of a large group response. We discussed this before, but we should treat each patient according to his/her individual response of all the risk factors, including positive responses and negative responses. And we can do that by using an algorithm, that famous pre-score, that calculates the renal risk for a patient on the basis of multiple available risk factors. So first we estimate their risk by using blood pressure, cholesterol, glucose, potassium, albuminuria, just like the advanced score, the KFRI score, or the Framingham score does that's the first thing we do. And we can use the multiple response score, the pre-score for that. Then if the risk is high, we start a therapy that changes these risk factors, as we are used to do now. But we first, before we know whether that works, we measure the change in all those risk factors and use the algorithm again to calculate whether the renal or CV response is reduced for that patient. So by the initial response to the drug in all these parameters, we can tell this patient is protected, yes or no. Then we adjust the therapy if it isn't protected and change the dose or stop or start new therapies to improve it. And we repeat this cycle until there is the target protection that you actually is acceptable for patient and doctor that you have established together. We obviously need, before we can actually launch this, to test this in a regular care setting and in a clinical setting. And we are currently working on doing that. I'm going to give you an example in the next slide sets, how that could work in your practice, what it would look like to do this in clinical practice. And this is a computer screenshot. I'm sorry that I cannot do it alive. I would have loved to do it alive. But this computer screenshot tells you is connected to, you have to imagine this, to a big database somewhere up in the clouds. And it does two things. First of all, it shows you here what your patient visits in this particular part of the slide. And is 1, 2, 3, 4, 5 visits. And it shows you the level of certain risk factors: body weight, HbA1c, blood pressure, urinary albumin, cholesterol was here, urinary albumin, and potassium. That level of that parameter, if you integrate the level of these risk parameters, then you can calculate the risk of that patient. And that is depicted on this side of the slide. In the red bar, I'm focusing on the renal component particularly now. The blue is the cardiovascular. So you see there is an increased risk of about 15% in these patients. You probably cannot read the numbers, but you have to believe me, it's about 15% risk of this patient. You see here on the right-hand side which parameters are actually contributing to the risk. And if you focus on the red one, you see that albuminuria is contributing the most compared to the others to the residual risk in this patient, despite the therapies that this patient has. Now, you would like to see that albuminuria is, you tell the patient and you say, let's see if we can lower your albuminuria by giving you a increased dose of, let's say, the enalapril, or add another ACE inhibitor. And you see that the next visit he comes back and you have lowered the albuminuria from 200 to 70. And you see here that that indeed has reduced the renal risk considerably. And nothing else has happened as you see it at this moment here. I'll come back to it later. And you see that the total risk is reduced as well. But you still say, I'm not fully agreeable, so I want to also check whether I can do something else. So in not only looking at albuminuria, we now also lowered the HbA1c, which was rather high, 8.1 to 5.6, and you see that also has a contributing factor to lowering the renal risk even further. And so you can go on. The next one is I'm lowering the blood pressure further. Here, systolic blood pressure has fallen further and has a not much, but a little contribution. And so you can tweak what you want to lower or increase the risk, both for cardiovascular and renal outcome. At the same time, you can also look at the negative effects, right? So the ACE inhibitor could have increased the potassium, as I mimicked here, and then you see that you have an increased risk for that component for the renal outcome. This type of interactive exchange that you can have with your patient, but also as a doctor for predicting what you should do with that patient, gives you the future outcome of a much better care for that individual patient. So in the future, my closing slide, to find new and better drugs for patients with chronic kidney disease, we need new trials that evaluate the effect of a drug based on multiple risk factors rather than on only the target parameter. And if we have done that, to use this drug effectively in practice and to lower renal risk in individual patients, we need new clinical decision support systems that are based on individual risk estimation and individual response estimations. This will improve a finding of more selective drugs, improve patient adherence to the right therapy, improve risk control of all factors, improve renal and cardiovascular outcome, and ultimately will improve pharmacoeconomic performance. I think this is the way forward for all of us. We are not there. We need a lot to do, but this is certainly something that you can already apply in your practice by the way of thinking about how to approach an individual patient. Thank you for your attention.
So thank you, Dick. Very clear, and I think a summary of all the trials, the work you have done over the past years, and I think you are working on it. So to the audience, you still have the chance to ask questions in the chat function. We already received a number of questions, but we have some time and we try to work through all the questions. So I think I will have a first personal one before we go to the question is that you selected a number of response parameters for the score. And I saw them clearly. Potassium was based on the renal, I think. And my question is, we talk a lot about biomarker. Do you have an idea and think when we are ready one time to also have a biomarker which we can include in this score, or are we far from it, or do you see already one on the horizon? Would this be a concept also?
Thanks, Christoph. This is obviously a very important question. The biomarkers we used are validated in trials that have actually measured the biomarker so that we can use that background database to link such a biomarker to an outcome. If in a trial you did never measure the biomarker, you cannot also not link it to this outcome, and we cannot use it in the response score. So there are two things happening. One, there's a huge a consortium that is working in Europe and also in the US, looking for new biomarkers, but also looking for trial data where we have samples stored so that we can actually look back in trials that have been done and see what a new biomarker that you measure in the stored samples of that trial would have done if you added it to the multiple response score or exclude parameters from it. Ultimately, I hope obviously that you can find one or two biomarkers and actually do the whole trick, right? But I think that for now, we are still very much heavily depending on those clinical and old-fashioned biomarkers that we all know about. And the new ones like TNF alpha receptors or the CRP or things that where we think that they could help us have not been able to actually add enough. But the research is ongoing, and as we speak, I would say, and Beat DKD is a initiative that has been running for a long time now and is trying to find out these exact new biomarkers that we could use and add to the current ones that we are using in this multiple response score.
Excellent, thank you. And maybe you have asked already your questions, and I ask the studio now to bring in these questions which arrived. And here is one. And the question is, how can we access a pre-score algorithm? When is it coming? Is it then free? Is it validated in clinical studies? And let me add, maybe you can tell me in what real-world databases you are validating currently these pre-score algorithm.
Yeah, thanks. So first of all, yes, if we have it and if we validated it, it is free. If you want to use it, you can also always use it, and you have to contact us. But I think for clinical practice, as we are used to work with each other, we first need proof of concept and proof and evidence of validation before we can actually do it. What we have shown you that we can work with it the way that we did it and that it actually predicts trials. I think that status is very interesting for, and we can do that, right? I mean, there's no objection to it. But for the use in actually your individual practice, we are validating it at the moment. And the one thing that we are doing is we have, well, I mean, maybe next week or in a couple of weeks, we will launch it to be submitted to EMA and FDA with all the data that we have to get it approved for use. So that's the one step that we are doing at the moment. And the second one is then what we would need is validation, which we would like to do in practice rather than to do it before that in general practice and clinical in real life studies, because what you obviously need for it is a background of true outcomes, right? You need the real studies, the studies that have been completely regulated and where the outcomes have been validated, to say it that way, by a committee to really make the score. but use it in practice will be something that we are going to do when it is a approved tool, and then everybody's happy to use it, and we will validate it in trials on the run, to say it that way.
Excellent. Can I have the next questions from the studio, which is coming in? So the question is, how do you explain the failed result of soludexide you mentioned when integrated it into the pre-score model?
Right, that is a very
really
intriguing
fail?
question. Yeah, that's a very intriguing question. I don't know who's asking that one, but we are to do a pre-score, a multiple risk score, and a prediction even post hoc. You need to have the database of a study because you need to do it by the individual, right, to see all the responses that are happening. And I'm sorry to say, but we were not able to get the database from the company to test it in soludexide. If you ask me why did soludexide fail and could we have predicted it, the answer is yes, because we know again that with soludexide there is also a very interesting phenomenon happening. First of all, we would have never started the outcome study when we would have done the pre-score, because the soludexide was actually the pre-studies were done with a different drug than actually the hard outcome study. And the second one is that the heart failure and the problems that were actually arising from this study were actually such that we could have seen that beforehand and done something about it, because then we would have stopped it. The effect on the renal outcome is actually, if you exclude the ones where the patients with the bad outcomes, if you exclude those beforehand, then soludexide would have been a great hit. So this is a good example of where this tool would have worked beautifully, because it could have predicted that the sodium retention that occurred would actually be offsetting the whole phenomenon of the renal outcome in the trial by increasing the risk for heart failure.
Very specific question, apparently. So can we have the next questions on the screen? And there is one very long one, so let's concentrate. Risk factors you mentioned for blood pressure, for example, is very variable as we evaluate it in usually clinical practice or in clinical trials. Do you think that the concept of pre-score is more efficacious with better evaluation of the risk, for example, ambulatory blood pressure measurement for evaluating the blood pressure?
A great question. Thank you very much. The answer is full-hearted yes. We need obviously good data in to get good data out. If you just have garbage data to go in, and that not only applies to blood pressure, but also to albuminuria, to some degree also to potassium. If the blood drawing is not done correctly, you can have increased potassium levels that are not valid. Albuminuria is very fluctuating between the different samples that you take from subjects. So yes, you need to get multiple data from the patient to be sure what the blood pressure is, use the right techniques to do it, the most accurate, to actually also get a good response score for that individual.
And albuminuria would be UACR best, or?
Yes, that's until now still surprisingly, because I would have expected 24-hour urine would still be the best. But surprisingly, the UACR, meaning the first morning void urine, is still doing very good in a group setting. For individuals, we haven't tested it yet, and that could change. But I definitely think that for the moment, that is the way to go.
Okay, thank you. Next question, please. So and here we have one. Please, can you explain the differences between precision and personalized medicine a bit in more detail?
Yeah. I don't think that I should go that direction for two reasons. One is I don't know, and secondly, I don't think that anybody knows. But I think that they are a little confusing, to say that at the least. I think the best definition is actually precision medicine, because you want to do something more precise, right? But at the same time, you exclude the person out of that. So personalized tells you that you actually wanted to do for only that individual. So they are, maybe the best combination is PP medicine. So precision and personalized, both of them, because that's what we actually aim to do, right? To see in a patient. So if maybe somebody's going to ask me this, but then I've answered it. What would you do for the renal patients ultimately, right? What is the best way of doing it? Is not waiting until that patient has responses on all these parameters. But the best thing we could do is do something very old-fashioned, is biopsy the organ, right? And see what is causing the disease in the organ. And is there a mechanism going on that you can actually intervene directly, like we are doing in oncology? And even in BDKD, we are trying to start that up. If you look at the work of Matthias Kretzler in the US, you see that he is building these models that you get out of biopsies to know which mechanism plays the most important role in that biopsy of disease, and then choosing a drug for that is obviously the best way. And then you are precise and personalized.
And then, do we have another question? Otherwise, I would have one just right now that, let's do it. Let's respect the audience. Your lecture was focused on renal and cardiovascular risk in patients with diabetes. Do you see a potential to use this approach in all fields, or do you see a limitation for areas like oncology, hematology, etc.?
Oh, very interesting. I think actually when I look at what we are doing, we are stealing already a little bit from the oncology field and hematology fields when we're talking about the risk itself, right? I mean, they are much more the precision or the personalized approach to it. The other hand, I think our approach of looking at response, which has been done also in these fields, by the way, that response is a very intriguing way to go. And it obviously applies to anything, right? I mean, if you look at what the infectious disease did by looking at the response in the Petri dish, which I think is really intriguing to do, then yes, it goes to all the arenas. And it goes also to all the arenas of renal disease. You can do it in focal sclerosis, you can do it in IgA nephropathy, you can do it in lupus, you can do it in, but you can also do it in what you say, the oncology and the hematology fields, and wherever you want to go, definitely.
I think we can take one more question, please. And here it comes. Just recently, we had a study with finerenone, the Fidelio DKD. And the Fidelio DKD had a moderate potassium signal, 0.2 millimole. And if you have potassium from the RENAAL trial in your algorithm, a huge potassium signal would not come out very well if you have an individual and enter the data, right? Do I understand it correctly?
Right. So we actually talked to the company beforehand that we would love to test in their in the phase 2 studies of them, what would be the outcome of finerenone if you would put the model into the multiple response score. By looking at the outcome of the finerenone study now, by just looking at what the average potassium did, what the average blood pressure, the average albuminuria did, you won't be able to calculate an outcome. What you need to do is how many patients had a high rise in potassium, and for instance, no change in their albuminuria, and how many had a big fall in proteinuria, but no change in their potassium, because that determines for the individual how the outcome for that individual would be. And if there is if they all go the same direction, then obviously the general outcome could be calculated from the averages of the group, right? But if the individuals go in different directions with their responses for the different parameters, there's nobody that can tell by head what the outcome would be. And I bet you that and we would love to do it, so I hope that the company allows us, even in a post hoc analysis, that we could have predicted that finerenone would have been much better in a setting of a sonar study where you selected out patients with a bad response in their potassium and a good response in their albuminuria, because then you would have created a niche in which finerenone would have maybe even lowered it by 50% further. And that is a future that I would like to see, where companies allow, certainly when they have drugs that have a negative and a positive effect, that they allow us to, and not us as us, but the community, to test the balance between the two of them, right? And to see what the outcome would be, because and then select on it. And I think that that is really the future. An SGLT2 inhibitor doesn't need the multiple response score, because it tells the story. It only has positive effects. The only thing you see is that there are a lot of patients not responding also to the SGLT2 inhibitor. And that's why you could even improve the effect of an SGLT2 inhibitor by selecting out the patients that are responding well with their multiple response score. And then just saying to the others, maybe you need another drug, which is better. So I think that our multiple response score can help even in positive trials to get them better and to get even more individual approaches.
Very interesting. Great. I get a signal that the audience is still with us because the discussion is so interesting. So we take another question. And okay. The question is, what do you think what do you think about measuring proteomics as predicting outcome, or introduce proteomics into the score?
Yeah, great. In BDKD, I told you, we are, for those databases that we have of all trials, we are actually doing the full metabolomics, proteomics, genomics, everything is done, so that the whole system biology of that trial, so the trial where we know outcomes, can be measured by the responses of these different measurements that we are doing, and then comparing them obviously in the outcome by integrating them again in the multiple response, and then comparing with the classic factors. So the work is being done. We have, unfortunately, a lack of enough trials where we have samples. Because you know what pharmaceutical companies do? They throw the samples away. It is unbelievable. So if we had everything from all these failed trials, we would have had a beautiful database, right, of looking at your question. But definitely that's the way that it should go and would go, that in the far, far future, I enjoy very much looking at movies that are talking about the future. And so I can picture it a little bit in front of me, that it is indeed like it is in whatever is Star Trek or whatever, that we just aim a little device on an individual, and from that aiming of the device into that individual, we tell what that disease is and how we should treat it, and maybe even inject it from the same disease. And that only comes from things like metabolomics and proteomics, or even in the genomic part of it, because from what we are doing now, that is would then be talked about as very old-fashioned.
Thank you, Dick. This was great. I think everybody could feel the enthusiasm and the dedication you have in this field, and this is the success why you carry this forward. So thank you again. We are coming to the end. I think this was such an interesting discussion that it will stay on the web, and we can look at it again in the upcoming future. And thank you for this glimpse into the future of this interesting topic. Thank you very much.
You're welcome.
So I will just mention or remind you that we have another webinar December 3rd, then webinar number 7. And we have with us Professor Sharon Kuhlmann and Dr. Len Uzivat, and they talk about or discuss the wearable health devices and personal area networks to improve hemodialysis outcomes. Thank you for being with us tonight, and I wish you a good evening. Goodbye.